Okay. Okay, so this is an MCQ session, and I don't know exactly. Probably we have gone through some of these MCQs, but there is no harm in doing it again. The MCQs to me is just a food for thought. So we're not gonna, our purpose and intention is not to have the same MCQs coming in the exam, but to make an MCQ a source of knowledge. So we're gonna expand widely as we go through these MCQs. The first one is, okay, chronic cardiorenal syndrome is most likely due to decreased renal perfusion due to decreased cardiac output, increased venous pressure, hypoxemia, electrolyte disturbances, or a disease affecting the kidney and the heart simultaneously. So which one do you think is right?
The answer is B. Mainly due to venous pressure and diffuse pressure.
B. That is Maha, right? Maha, you have chosen B, right? B, huh? Increased venous pressure. Huh?
No, she's Rayan. The answer was D by Rayan.
Sorry. Rayan
Yes,
has
yes.
chosen increased venous pressure. Rayan, that's a very courageous answer, actually, because it conflicts so much with more commonsensical one, which is number one, A, decreased renal perfusion due to decreased cardiac output. So why have you chosen B and not A?
Number one, because it is chronic cardiorenal syndrome, not an acute. يعني firstly إنه بيحصل adaptation في renal system to adapt the low cardiac output. But because there is increase in the preload and the venous return, that leads to this syndrome.
Great, great. This is nice answer. So the right answer
in the venous, sorry, I think in an acute, there is usually increase in the venous pressure.
In the acute.
Yes.
Okay. Yeah, to be honest, when you have heart failure during the acute or chronic phase, you have both on board. You have decreased cardiac output and you have congestion. But probably in the acute heart failure, you tend to, and it tends to manifest itself as low cardiac output, much more than by congestion, while the chronic heart failure, more of congestion and less of problem of cardiac output. That brings us to the classification, the fourth classification, the clinical classification of heart failure into warm and wet. I mean, warm and cold, wet and dry. Okay? Because if you are cold and wet, that means you have decreased perfusion and congestion. If you are warm and dry, means you don't have congestion and the cardiac output is reasonable. And there is scenarios in between. Okay? But in chronic heart failure, by the way, and even acute heart failure, the renal affection is basically primarily and essentially is due to increased venous pressure. Decreased perfusion to the kidneys is another factor which comes second in importance. The most important is the increased venous pressure. And this one has implication on the management, isn't it? It has implication on the management because of if increased venous pressure is the primary cause of renal deterioration in the setting of acute and chronic heart failure, معناتها you have to target congestion by all cost. Okay, and actually being alarmed that giving more doses of diuretics is gonna worsen the kidney function is exactly paradoxical to the actual mechanism. Because in these scenarios, actually, if you give good doses of diuretic to relieve the congestion, you are doing good for the kidneys and not bad. Okay. So remember, cardiorenal syndrome is so important. And just a quick review of the 5 types of cardiorenal syndrome. We have type 1, which is acute kidney injury in the setting of sudden deterioration of heart function, meaning acute heart failure and decompensated heart failure. Cardiorenal syndrome type 2 is a progressive renal dysfunction in the setting of chronic cardiac dysfunction. Type 3, sometimes they call it renocardiac syndrome, renocardiac, because the renal dysfunction is leading to cardiac dysfunction. Okay, renocardia. Or cardiorenal type 3 is acute deterioration of renal function leading to acute heart failure. And cardiorenal type 4 is a chronic renal failure leading to chronic heart problem or chronic heart failure, progressive development of chronic heart failure. Type 5 is a combined cardiac and renal dysfunction caused by systemic illness. Okay? So now you get the point, right? So like type 1 and type 2, you expect to be dealing with these patients as primary patients of yours, and you refer them to nephrology. Type 3 and 4, actually, the nephrologists are referring patients to you in cardiology because basically they are affected by renal failure and secondarily they develop some problem in the heart. Okay. I am for the last 5 years, actually, I'm leading the service of cardiorenal, cardio-nephrology clinic. I'm basically dealing with type 3 and 4. So patients who develop acute or chronic renal failure, how the heart is affected and how you are gonna manage this heart, which is sick as a result of a problem in the kidneys. And that's which leads to the very, very difficult and sophisticated and complex topic of cardiorenal interaction and crosstalks. And you know, how these 2 organs are avidly connected and how you are gonna manage when one leads to a problem in the second, okay? So this is really a big topic. If we have time later, we might have a dedicated session for it. Okay. Now, second question. All of the following are no risk factor for peripartum cardiomyopathy except advanced age more than 30, primiparity, twin gestation, use of tocolytic therapy.
هو a disease of multiparity.
Also be.
Okay. So you're right. So yeah.
So my
answer is B.
B. Yes, correct answer B.
Oh, okay. So advanced maternal age and multiparity and twin gestation and prolonged use of tocolytic therapies are known to be risk factors. Now, peripartum cardiomyopathy, the definition is what? How can you define it?
That patient develop heart failure in a normal structure heart disease 1 month prior to the delivery and 5 months after.
1 month and 5 months
after delivery, yes.
Yeah, so the last month of pregnancy up to 5 months afterwards. So a total of 6 months, right? 1 month, 5 months. Remember this one, okay? Without pre-existing cardiac disease.
Yes.
Or without known pre-existing cardiac disease. Okay. So how are you going to treat peripartum cardiomyopathy? You are going to treat it along the conventional tracks of therapy for HFrEF, right?
Yes, of heart failure, yes.
Even you are going to give ACE and ARBs?
No, it's contraindicated.
During pregnancy, yeah?
Yes.
So probably this is the only one you might be skeptical about. Now, the other thing is, how is the chance of full recovery?
50% will recover totally.
Okay.
And 30 of them, of the 50, can develop another postpartum and another pregnancy.
Very good. طيب يا Maha, if a woman who had a history of peripartum cardiomyopathy wanna conceive again, how are you gonna counsel her?
I will talk about the risk of developing another attack of cardiomyopathy, which can be ended by dilated cardiomyopathy.
So
Not recommended.
It's not recommended. So you will try to talk her out of this option.
Yes.
You all agree with that? Do you all agree with that?
I think it's not like contraindication. Yes.
Sorry?
Dr. Hatim, it's not one of the contraindication of pregnancy, like is a Menger and other valvular and primary pulmonary hypertension. It's not at that class.
Okay, so it's a matter of counseling, you know. So,
Yes.
if a patient completed her family is not like, you know, other scenarios and stuff like that. And there is a way that we can reassure ourselves as physician and the patient is herself by doing some workup. Yani, I tell you something. If a patient had severe LV dysfunction due to peripartum cardiomyopathy, I think even if she recovered completely, you should advise her against pregnancy. And by severe, we mean something lower than 30%. Okay? Because if it recur, it will recur with the same low level, and that will be so serious. Like if she developed peripartum cardiomyopathy with an ejection fraction of 40, 45, even if it recurs, that wouldn't be so fatal or so serious. So if the ejection fraction has a lot to do with counseling the patient. The other thing is, if the patient still has residual LV dysfunction, I think you should also counsel her against pregnancy. But if she recovers completely, yes, we might go for pregnancy, you know, with a pinch of salt. Okay, so we are talking about patients then who had no severe LV dysfunction, who recovered their LV function almost fully, and now they are willing to conceive. These patients, it will be so wise to put them on a stress test. Why we do that? Because a stress test is gonna reveal an occult LV dysfunction. So now, as per their echo during rest state, it's fine. Like in how the LV function is gonna behave if we stress the patient is something else. So if I stress this patient on a treadmill, for example, okay, and I check her ejection fraction after stress and it's still normal, then I might be reassured that the chance of recurrence is lower than if her LV function deteriorates during exercise. Okay? Good?
Okay.
Okay. So, wide variable responses to warfarin is explained by variable pharmacokinetics, pharmacodynamics, clearance, bioavailability, or brands of drugs. When you have witnessed how warfarin is kind of a difficult medication to deal with because some of our patients are taking 2 and their INR is 3. Some are taking 20 and the INR is hardly above 1.5. So there is variable responses among individuals to the same dose of warfarin. Okay.
I think
So this is explained by what?
Bioavailability.
Bioavailability.
It has narrow therapeutic range.
Narrow therapeutic range. Okay. Narrow therapeutic range معناته the range between the therapeutic dose and toxic dose is narrow. Like in digoxin and warfarin as well. Yeah, I agree with you. Yeah.
Pharmacodynamics, yes, I think.
Pharmacodynamics. Exactly. Exactly. It's pharmacodynamics. So what is pharmacokinetics and what is pharmacodynamics? Pharmacokinetics is what the body does to the drug. So absorption, distribution, metabolism, and elimination. Pharmacodynamics is what the drug does in the body. So it's efficacy and toxicity. Now, efficacy relates to the how the drug binds to receptor, how it's internalized, and how it produces an effect. This kind of mechanism is different from individual to individual due to variation in pharmacogenetics. Okay? There is wide variation in pharmacogenetics between individual, لكنها it affects the medication differently. In warfarin, the effect is robust. That's why we are seeing this wide variation in dosing warfarin to different people. Okay, so it's basically due to the efficacy of the drug is different from person to person due to pharmacogenetics. Okay. All of the following are technical problems in severity assessment of the mitral stenosis, except the use of planimetry of the valve and missing the lowest obstruction. The use of pressure half time in context of advanced grade of diastolic dysfunction. The use of planimetry in the presence of ASD. The use of planimetry post-ballooning.
Except
Pressure half time.
in presence of ASD, the best method is
Planometry after post-ballooning,
The
we need
ASD.
to depend on.
Planimetry post-ballooning, is it a problem or it's not a problem?
It's a problem.
It's not a problem.
It's a problem.
Usually-
Why it's a problem?
We didn't do it that usually as usual. We depend
Why?
on the
Why,
pressure half
Maha?
time.
Why? Why, Maha?
Because
Tell me
there
why.
is already with ballooning, we attempt to rupture one of the fissures. So
Exactly.
I cannot exactly define the area and the margins.
Exactly. Yes. Because you know when you balloon a valve, you split the commissure. So you are creating cracks and fissures. These cracks and fissures are very difficult to planimetrize. Wherever you go, you find they are so elusive. So it's difficult to planimetrize them. So it's a problem. The use of planimetry post-ballooning is a problem. So which one is not a problem here? The use of, let's start one by one. C. The use of planimetry in the presence of ASD. It's not a problem. Who answered this question?
It's not a problem. It affects pressure half time. It
Yes.
not affect the planometry.
Exactly. You are so right.
Yeah.
Yes, yes. So if you have an ASD, that ASD is taking blood away from the mitral inflow. So that is going to affect the pressure half time because it's flow dependent, but the area is not flow dependent. So the area by planimetry is not going to be affected by ASD. It's not going to be affected by MR, okay? But the pressure half time is definitely going to be affected by the ASD. That's why ASD tends to underestimate mitral stenosis based on pressure half time, okay? So what about B? The use of pressure half time if you have advanced grade of diastolic dysfunction.
It underestimates the
Exactly.
Underestimate the mitral valve area.
Thank you so much. Why it underestimate? Because this pressure half time depends on the flow out of the left atrium into the left ventricle. So the longer the time it takes the blood to go from up to down, the more likely the stenosis is severe. That's the theory of pressure half time. Okay. Now, if I have a diastolic dysfunction downstairs, when the flow goes down, the LA pressure is high, so it tends to be like restrictive pattern. So there will be a very huge gush and abrupt cessation of flow afterwards, just like the restrictive pattern. So that is gonna shorten the pressure half time. And by shortening the pressure half time, you tend to underestimate the area based on pressure half time. Okay, so that's why if you have mitral stenosis and severe aortic regurgitation leading to diastolic dysfunction, you tend to underestimate mitral stenosis based on pressure half time. Okay, good. So what is the pressure half time to define severe mitral stenosis?
بسمع السؤال دكتور حاتم معلش.
What is the pressure half time that defines severe mitral stenosis?
More than 150.
150? 150.
I think it's 200. Or ذيك في الاستقبال. I'm not
Sorry?
sure. I'm not sure. Sorry.
More than 150.
Or 150, I accept that, or 147 maybe. But because what do you mean? If we have here the area by pressure half time is 220 over pressure half time equals the area, right?
Yes.
220 by pressure half time. So let's do this one. Yeah, exactly. So if I do it this way, so you have 220 over pressure half time, E half. Okay, that's the pressure half time. 220 over pressure half time. So if you need to have an area 1, معناته the pressure half time should be 220. But now 1.5 defines severe MS, right? So if you divide 220 220 by 146. 146. So 146 pressure half time defines severe MS. If your area or your definition of severe is an area less than 1.5, it's no longer 1, right? According to the guidelines, we used to go by less than 1 area, but now less than 1.5 centimeters square. Okay? Less than 1 defines very severe mitral stenosis. Very severe mitral stenosis is less than 1, but severe mitral stenosis is anything equals to or less than 1.5 centimeters square. Okay? Type. What about the first one? The use of planimetry and missing the lowest obstruction. Is this a technical problem? Is it a technical problem?
Usually in the planometry we have to estimate the lower area by بنعمل estimation للاريا في اللونج axis tip to tip. وبعدين بعمل اقارب بالبلانومتري عشان اجيب narrowest area يعني usually.
Exactly. So Anna, from my practice, I found, and according to the literature as well, the difficult technical part of assessing mitral stenosis is number A. Is how to define and where to define the lowest part of the valve where the obstruction is maximum. Because when you cut through the valve in the short axis, you might be a little bit up and therefore you underestimate the area. So you have to make sure that you are cutting through the lowest part of the valve where the maximum stenosis is there. How I can be sure? How can I be sure? How can I be sure?
بشوف في اللونج اكسس I will see in the long axis tip to tip the narrowest area وبعمل estimation عليها. معناتها البلانومتري should be valve area about الكلام ده بس مش اشتغلناه.
Yes, so you have two ways of making sure and going around this problem. One is the use of biplane technology of echo. X-plane, you know, X-plane and biplane and multiplane. Now in echo, if you click on biplane, it gives you two orthogonal planes. So parasternal long axis and short axis at the same time. So in the parasternal long axis, make sure that you are cutting through the lowest point, and in the short axis, you will see the lowest point. So biplane will show you where you are cutting. The other thing is 3D evaluation. So if you obtain 3D data, you can crop it so nicely and accurately, measuring the lowest point of the stenosis. Okay, good.
Okay.
So this patient is most likely to have large pericardial effusion, severe LV dysfunction, tamponade, pulsus deficit, frequent ectopics.
Inspection of tamponade, electrical
alternance.
Why a lot of large pericardial effusion?
Electrical
alternance.
Large
electrical alternance. Which sorry?
Is it due to large pericardial effusion, not necessarily a tamponade?
Thank you
Yes.
so much. Thank you so much. I definitely agree with you. Yes. But it can be a circumstantial sign of tamponade. Circumstantial means indirect, because the larger the volume of the effusion, the more likely to have tamponade. Yes, so indirectly, but it's not a direct. It's a direct sign of large effusion. And the heart is swinging into that fluid pool, coming back and forth to the chest wall. Therefore, the ECG is picking high and low electrical signals. Okay. That is, so what is the relationship of this ECG to pulsus alternans?
Pulsus alternans examination.
Examination, thank you so much. Does pulsus alternans have anything to do with ECG? Is it a diagnosis based on ECG, or are you going to see anything in the ECG if you have pulsus alternans? No. So the voltage will be normal. It's just that some of the beats are of low cardiac output to reach down there. So it's basically a clinical sign. But pulsus electrical alternance is an ECG sign and not a clinical sign. So you cannot find it clinically. Conversely, pulsus alternans is a clinical sign and no ECG sign. Okay? So remember these two. It's a source of confusion. So please make sure you now know exactly the difference between these two. Okay, now we have this 26-year-old lady. History of hypertension is seen for evaluation of, she had, again, 62-year-old woman with a history of hypertension is seen for evaluation of severe mitral regurgitation. She has a history of hypertension and otherwise has been healthy. She exercises regularly without limitation. Medication include lisinopril 10 milligram daily. You proceed with a comprehensive examination, including transthoracic echo. Which of the following findings on transthoracic echo represent an indication for mitral valve surgery? End systolic dimension of 3.2 centimeter, calculated LV ejection fraction of 58%, estimated RV systolic pressure of 40 millimeter mercury, subvalvular chordal fusion and calcification, effective regurgitant orifice of 0.2 centimeter square. So, who is taking this? So, what defines severe MR an indication for surgery or class 1 indication for surgery in these 5 scenarios?
I think E. Okay. First, B and C and D, there is no role in the indication.
B, C, and D?
Sorry. C and D. RV
C and
systolic
D.
pressure. Yes.
B.
B.
C and D. Out.
Yes, less than 60.
Okay. So I think, who said B? Adam?
Effective regurgitant orifice.
Yes.
أيوة.
Adam, you said A, B, right?
Yes. Because ejection fraction is low.
Aha. So what is class 1 indication based on ejection fraction in severe MR?
Less than 60.
Less than 60%. Exactly. So don't say 58 is close to, no. You have to take a proactive step, because you know, if severe MR, see, you are still going to operate on patient of severe MR as class 1 indication with good impact on the outcome, as long as your ejection fraction is better than 30%. That's why in the guidelines, if your ejection fraction is lower than 30%, the surgery is no longer class 1 indication. So don't wait too long.
Yes.
So if the ejection fraction falls lower than 60, you have to operate. But isn't that too much? Yani 60. Why? Is that coming from any fury or any
60
science?
60 in case of severe MR equal like 30.
You are so right. Why? Because in severe MR, we expect the LV to be hyperdynamic, to see an ejection fraction of 60, 70, and stuff like that. Why? Because severe MR decrease the afterload, and this will lead to hyperkinesis. Okay? So 60 and below 60, in context of severe MR, is depressed LV dysfunction, is depressed LV. Okay? And now we sometimes use the strain, and patient of ejection fraction, which is 60%, they have low strain. So a strain is kind of revealing the occult LV dysfunction, which the ejection fraction fails to reveal. But still, using strain is not in guidelines. But sooner it might be. Okay? So now we agree that ejection fraction lower than 60 in context of severe MR means depressed LV function because of so and so, and you better operate as class 1 indication. Now, in systolic dimension, what is the measurement that indicates surgery as class 1 here?
40 or more.
40 or 45?
40.
Sure? I'm not so sure. Is it 45 or 40?
It's 40.
Yes, 40.
No.
$40. Hatim out, right?
شكله دكتور حاتم اوت.
ما في في هوستل اتهال لو دكتور حاتم أذكر إنه be added على الله دخلنا. بالنسبة للشنطة يا شباب
ابتهال انت الهوست يا ابتهال. دكتور حاتم طلع. try to add him يعني if ابتهال موجودة. الو
اضيفه كيف؟
هو حيجيكي بس
هو بيجيكي بيظهر لك في السكرين. عمل لك acceptance هاي يعني.
خلاص
ما ظهر لي والله.
لا شكرا
دخل هاي خلاص.
شكرا لك.
Hi, how are you? I'm back. I don't know how I get out, but I'm back. I gave you a break. Okay, so let's go back, sorry. So we stopped at this one. So yeah, but just please revise the end diastolic dimension. Is it 45 or 40? I'm not so sure.
Yes, it's 40.
40. Okay, خلاص. So ejection. So end systolic volume equals to or more than 40 is indication of class 1 indication for surgery. Now, what about C? C. Now, if I have pulmonary artery systolic pressure of 50, 55, will that be indication for surgery?
50 or more. 50
If
or
it's
more.
55, will it be indication for surgery?
Yes.
Class?
Plus 2. 2A.
Exactly. So it's not class 1. So class 1? Yeah. So it's not class 1, exactly. It's not class 1. Like the dimensions, systolic dimensions, is it class 1 or 2?
Yes.
Huh? The dimension, the end diastolic dimension more than 40. Is it
systolic,
class 1?
you mean?
Yeah, yes, systolic. Class 1.
Class
So
1.
we have 3 indications as class 1. Symptoms with severe MR. Ejection fraction lower than 60 with severe MR. And end systolic dimension of more than 40 with severe MR. Only 3. Okay?
Okay.
Good. And of course, severe MR going for other cardiac surgery is also class 1. Now, what about effective regurgitant orifice of 0.5?
It indicates severity, not indication for surgery.
What is the indication of severity based on ERO?
F40. F4, 3 to 4.
Yeah, it's 0.4. And in AR? And in AR?
0.6.
No, that's the vena contractor. That's the vena contractor. This is not the vena contractor. This is not the vena contractor. This is the ERO, effective regurgitant orifice.
تقريبا أصغر من بتاع المايترال.
أصغر من المايترال 0.3.
Yes.
0.3 and 0.4. And أصغر من المايترال ليه? Why? Why we need a lower ERO to define severe AR and a bigger ERO to define severe MR?
I think because the LA and the LV chamber differ from the aorta and the LVOT يعني
Good idea. Good idea. طيب يا ريان خلينا نشوفها الآن. You said it's because of pressure gradient. طيب ال MR is driven by LV pressure minus LA pressure. Let's assume that we have LV systolic pressure of 120 and we have LA pressure of 20. So the difference is 100.
100.
So what drives the MR is 100 millimeter mercury. Now let's go for AR. AR is the difference between the aortic diastolic pressure and the LV EDP. So let's say that the aortic diastolic pressure is 80. And let's say the LV EDP is just 10. The difference is 70.
Yes.
The difference is 70. So the MR is driven by a bigger force than the AR. That's why I should expect the ERO is smaller in MR than AR because the pressure here is higher than here. وليس العكس صح؟ يبقى there must be another reason. What is that reason? Anybody knows? That relates to the cardiac cycle and cardiac event. MR is the systolic event, AR is the diastolic event. And we know that systole occupies 1/3 of the cardiac cycle and diastole is 2/3. So AR has a longer duration to go from the aorta into the LV. There is a long time of oozing of blood backward. While in MR, the systole is a brief and short period. That's why we need a smaller area in AR because of a longer time of that event versus a bigger area for MR because of a short duration of that event. Okay?
Good. Yeah.
Great. Okay. Now, a patient following mitral replacement with St. Jude prosthesis has a high peak transmitral gradient with a normal pressure half time and no significant MR is seen by color Doppler. This may indicate which of the following: prosthetic mitral stenosis, significant occult MR shadowed by the prosthesis, the presence of SAM, ischemia, significant aortic insufficiency. Okay.
B.
B. Great.
Difficult
B.
one.
Yeah, go ahead. B. Who said B? Which is right? B is right.
Because of gradient is high.
Okay.
Mitral valve.
The gradient is high. But if the gradient is high, why it is not mitral stenosis or prosthesis stenosis?
Yes, because normal pressure half time.
Exactly. Yes,
Yes.
because of normal pressure half time. You know the MR and MS. MS and MR both are going to affect the flow from the left atrium to the left ventricle. When we have MR, what is usually affected is the peak pressure, but not the mean, because the MR will go, the initial phase will go so fast under high pressure to the LV and no any more of pressure. But in MS is uniformly high pressure because the stenosis is imposed on the flow across the entire diastolic period. So that will influence the peak and the mean. So the peak will be high and the mean will be high. But if I have peak high and mean is not that high, That suggests more of MR than MS. Okay, so in this case, I have MR. Why didn't I see MR? Because of the prosthesis shadowing, acoustic shadowing.
Yes.
So what are you gonna do next?
Transesophageal echo.
Exactly. Because in transesophageal echo, as we have explained before, the shadows are going to be shifted into the LV and the left atrium is going to be devoid of acoustic shadowing. So you are going to see if you have paravalvular leak. But in transthoracic echo, from the gradient are taken from the apical window. Remember, when you imagine, now imagine with me the apical window with a prosthetic valve. Acoustic shadows on both sides, a reverberation in the middle. So the paravalvular jet is coming right into a black hole. It's not seen because that's acoustic shadow.
Yes.
But in TE, you are gonna circumvent this problem for sure, and you are gonna see if you have, whether or not you have paravalvular. Okay?
Okay.
Good. We have done this one before. I wish you still remember because it's very, very nasty MCQs. Which one of the following is not a deterministic effect of radiation? Nausea and vomiting, aplastic anemia, cataract, skin burn, and cancer.
كانت كانسر مش؟
Cancer. That's why we cannot remember.
كان في فرق بين الديترمينستيك افكت انه
Okay.
نصحي في شكلنا.
Yes, that's good. So we have deterministic effects and stochastic effect. Stochastic means probabilistic. Probabilistic. Deterministic means inevitable. حتمي هيحصل. أما stochastic is probabilistic. So deterministic, which is inevitable, حتمي إنه يحصل if and only if you exceed a certain dose. يعني الآن, if you exceed a certain dose in fluoro, patient might get skin erythema and ulceration. If you exceed a certain dose, patient might get aplastic anemia. So these are all dose dependent. Deterministic effects are dose dependent effects. So you are deterministically gonna get them if you get that dose of radiation. While stochastic is probable effect. That is cancer, which is cumulative effect. It's called linear non-threshold model, LNT. Linear non-threshold. يعني شنو linear non-threshold؟ يعني the more you get radiation, the more your chance of cancer increases. When are you gonna get cancer exactly? Nobody knows. Because there is no threshold of certain radiation after which you are gonna get it. You can get it anywhere along your exposure. Because every exposure increases your chance until you get cancer, but nobody knows exactly when are you gonna get cancer. But we know that we have linear response, but non-threshold response. And this is why بيقول لك the best إنه أنت you avoid radiation لأنه ما معروف when you are gonna get it. And that's the concept ALARA. You know the major famous concept in radiology, ALARA, which is as low as reasonably achievable. ALARA is as low as reasonably achievable. يعني you use radiation as low as reasonably achievable. أقل radiation تقدر تستعمله for this imaging, use it. Reducing radiation as much as you can. Okay? Because of this LNT response, linear non-threshold response. Okay. Now we have this 63-year-old man present with fatigue, exertional dyspnea, nausea, dizziness, orthostatic hypotension. After his initial evaluation, transthoracic echo is obtained with representative images. I'm going to show it to you. And CMR is done as well with gadolinium. Again, I'm going to show you the images. What is the most likely diagnosis? Again, I'm expecting you to answer this one at the snap. So the image on top is echo. Yes, so this is amyloidosis.
Amyloidosis.
Why? Can you
There is-
explain what you are seeing in the
There
echo and
is-
what you are seeing in the MR?
in long axis
ما
view
she's going
حافظة طبعا أنا حافظة.
Uh-huh.
There is concentric LVH with dilated LA, and there is minimal pericardial effusion in the long axis.
And if you look at the ECG attached to the echo, it's low voltage as well, right?
Yes.
Okay. تمام. And
ريان
what
ممكن
about
تاخذ
the
الام ار اي يلا ريان.
الMRI?
الايمجنج يعني عنده global
Global subendocardial enhancement.
enhancement.
Huh?
Yes.
Yes,
Yes.
which is characteristic of amyloid. And again, I just want to remind you of the different pattern of delayed hyperenhancement. I'm going to go through them because we have explained them last time. But remember, in MRI, the beauty and the strength of MRI is the definition of hyperenhancement pattern, which correlate to different sort of myopathies, cardiomyopathies, and ischemia. The one on the left defines ischemia. Ischemia is subendocardial. It starts subendocardial, but it might involve the entire wall. While cardiomyopathies, by and large, are mid-wall and subpericardial. Okay, so you can know from the pattern of enhancement if you are dealing with ischemia or a different sort of cardiomyopathy. Now, Hookham has a characteristic hyperenhancement pattern in MRI, sarcoidosis, Fabry's disease. So the CMR guys know exactly what to do and how to analyze the pattern in the best diagnostic ways. Okay.
Okay.
Now, which of the following are signs of severe? All of the following are signs of severe regurgitation, except one. I think, you know, MCQs are soon gonna be without except, because except is the nastiest part of MCQs. Okay, for sooner, I think even in the exam here, they urged us to stop using except in MCQs. So I think even in Sudan, I think if they have to go by MCQs, except has to be out. Okay, but anyhow, all of the following are signs of severe regurgitation. So see what are the signs of severe AR and show me which is not. Okay, you can go and read it.
Right. The systolic flow reversal in the descending aorta, definitely it is a severe AR.
Okay, so the systolic flow reversal in the descending aorta is severe AR.
الفي max through the aortic valve of more than 5 milli per second indicated of aortic stenosis.
Okay, so Vmax of 5, yeah, Vmax of 5 corresponds to peak pressure of how much?
100.
100. Okay.
Functional.
So that defines severe aortic stenosis, not aortic regurgitation. Okay.
Yes.
So the answer we are gonna choose here is C. But let's go through pressure. Somebody said that systolic flow
Functional
reversal.
of AS.
Sorry.
Functional of AS.
Which one is this? Come again.
هو قال إنه الفي
I mean,
ماكس
Vmax more than 5 is the feature of severe MS. Severe AS.
Yes, severe AS, because that corresponds to a peak pressure gradient of 100. And this defines severe aortic stenosis. Now, diastolic flow reversal in the descending aorta, I hear somebody said this is definitely a sign of severe AR, and I just underscore the word definitely because it's not definitely.
Definitely, yes.
Can you make any correction to be definitely?
If it is an abdominal aorta,
It's definite, exactly.
Yes.
So, definitely is not a good word in medicine. Like yes, the probability is so high with if the reversal is found down in the abdominal aorta, meaning the AR is so severe as to come back from the abdominal aorta. Exactly.
Yes.
But in the descending aorta,
it could be moderate or severe.
Could be moderate and or severe, even mild, even normal. You can find diastolic flow reversal in mild, in moderate, in severe, and in normal healthy patients. You know, so we have to go quantitatively here, by the way. It's not any reversal. It has to be hollow diastolic. Hollow diastolic. Okay? And if you apply the TVI, which is calculation of the stroke distance, has to be more than 15 seconds or milliseconds. 15 seconds or milliseconds. TVI is millisecond. Yeah. Isn't it? Milliseconds, yeah. It has to be more than 15. Okay? You know how to calculate the TVI. TVI. Either you see it is. So by eyeballing, it has to be pansystolic. But it's better to apply TVI and you contour out the signal by the TVI, which is time velocity integral, and see how much of TVI is there. More than 15 is severe. Okay. Meaning there is a bulk of diastolic reversal. Okay. Now, which of the following finding is most diagnostic of constrictive physiology? Dip and plateau of left ventricular diastolic pressure, respiratory discordance.
No, it could be restricted. Yes, it's not.
Okay. Respiratory discordance demonstrated with simultaneous right and LV, or abrupt cessation of respiratory typhoid discordance tania. Number D. Respiratory discordance with simultaneous pulmonary wedge and right atrial pressure, or respiratory concordance between the two ventricles. So which one?
LV and RV. Concordance.
So constrictive, is it concordance or discordance?
Discordance. It's the LV and the RV.
So it is discordance.
Between the LV and the RV.
So you are choosing B.
Yes.
Okay, good. So what about dip and plateau? Square root sign of the diastolic curve.
Present in all.
It's not
in both.
Not
yes, exactly. So it's in both. So it's respiratory discordance. In restriction, we have concordance.
Concordance.
Why do we have discordance in constriction?
Because in case of inspiration, there is no drop in the, because in case during inspiration, the pressure in the left ventricle is high, so the reflected to the left atrium.
Okay.
And
there is interventricular dependence.
When we expect the LV pressure to drop, it will not drop.
Okay.
Resulting in
other words,
in case during inspiration, there is increase in the blood flow in the right side and decrease flow in the left side in normal person.
Okay.
And during expiration, the vice versa will happen.
Okay.
But in case of constrictive, during during inspiration, there is high pressure in the LV, so the pressure reflected in the left atrium, resulting in discordance.
Yes. Yes. So you're right. You're right. Surely you're right. So there are two, just to make it easier for you, there are two mechanisms of this discordance. I want you to remember what they are and then the explanation of each. One is the interventricular interdependence. Two is LA-LV gradient. So these are the two mechanisms. These are the naming of the two mechanisms. Interventricular interdependence, and the second is LA-LV gradient changes. Now, interventricular interdependence means what? Now, because the two ventricles are competing on a limited space, the septum will fall a victim to this problem. So when the RV fills, it fills at the expense of the, when the RV fills, it fills at the expense of the LV and vice versa. So during inspiration, we expect more flow in the RV. Therefore, the septum is going to shift leftward. And this will decrease the cavity in the left side. And this will decrease the flow out of the left side. So during inspiration, we are going to have low flow because of low LV cavity because of leftward shift of the septum. This is one mechanism. Is that clear so far?
Yes.
Okay. The second mechanism is that during inspiration, the lungs are inflated. The blood is pooling into it. So the pressure gradient of the blood reaching the pulmonary vein and the left atrium is going to be low or high?
High.
No, it's going to be low. During expiration, the lungs are shrinking back. So they massage the blood out with force. Yes. So the blood goes to the left atrium under high pressure. While during inspiration, the blood pools into the lungs and the pressure of the blood reaching the left atrium through the pulmonary veins is of low pressure. Until here, we are dealing with a physiological process. So physiologically, during inspiration, the pressure of the blood reaching the left atrium is lower than the pressure of the blood reaching the left atrium during expiration. But in physiological condition, the heart is gonna compensate for this lower LA pressure by lower LV pressure. During inspiration, the heart expands better. So there is a better or lower LV pressure. So the gradient is maintained and the flow comes normally. But if you have constriction, the left ventricle is isolated from the thoracic pressures. So during inspiration, the heart no longer performs better and relax better and drops the pressure as it's used in physiological condition. So the gradient remains low because we have low LA pressure versus still high LV pressure. So that gradient will be what? Will be low. And therefore, the blood moving from the left atrium to the left ventricle is low. This is a second mechanism. Okay?
Okay.
I know it's always tough. And every time I explain it differently, I get exhausted. Don't worry about it. Type. We have this 36-year-old woman has dyspnea on exertion, diastolic murmur, a mild hypertension. ECG AF, undergoes balloon valvoplasty procedure and discharge. 4 weeks later, she continues to be shortness of breath and returns to the cath lab for hemodynamic assessment. Now, based on this hemodynamic tracing, this is the hemodynamic assessment. So, what are you expecting in this patient?
Severe MR.
Exactly. So we're going to choose C, mitral regurgitation, late appeal. because probably they missed it during the procedure itself. Okay.
Yes.
Okay. So this hemodynamic tracing, can you read it for us? What does that mean?
Simultaneous hemodynamic between the LV and LA with ECG in a baseline السكور حقنا من 0 to 40 or more.
Okay.
Showing the LV.
Mm-hmm.
طيب ال LV هو more than
ما ظاهرة.
ما ظاهرة.
high LA pressure.
High
LV
LA pressure.
pressure.
What
Yes.
is high in the LA pressure? Huh? V wave.
The V wave, yes.
V wave. Al V wave defines what defines the venous retain. The venous retain. Usually,
yes,
the venous retain.
Yes.
But now we have a retain from the MR. That's why the V increased, because now there are two sources of retain, through the venous vein, pulmonary venous vein, and through the mitral regurgitation.
Regurgitation, yes.
Okay, so that's why we have this high V wave. Okay, remember, high V wave, as high as this one is MR, but you have to be cautious. Not any high V wave is MR. You have to have very high V wave, 50s and 60s pressure to define severe MR. لأنه حتى ال MS itself can lead to high V wave. Al VSD can lead to high V wave. Okay? So you have to interpret the V wave in light of how much it's high.
Okay.
لأنه according to how much is high, you can define MR, but not without how much it's high. Okay? Good. So this is MR. طيب, if I ask you here before we move, now the assessment for balloon suitability, you have to do something, some important essential workup, which is what?
تبع وين الMS يعني ولا؟
Yes, for MS, for MS, for MS.
To measure
the
the weight and the height.
The Wilkins
No.
score, if it is suitable for PTMC or not.
أيوة. So suitability for balloon valvoplasty depends on the Wilkins Pascal score,
Yes.
which encompasses which features you are looking for in echo.
Okay. The degree of calcification, mobility, subvalvular apparatus.
They are four. So which are they?
Thickness, yes.
Thickness.
Mobility, calcification, and subvalvular apparatus.
So exactly. So thickness, mobility, calcification, and the state of the subvalvular apparatus. They are four. Now somebody said MR. MR does not belong to this Pascal or Wilkins score.
Yes.
Okay. Wilkins score is assessment of the suitability based on the morphological features of the mitral valve and the subvalvular apparatus. Now, exclusion criteria for ballooning is moderate to severe MR, and that's a different one. Okay. So before ballooning, you have to do three exclusions. One, you have to exclude that, or you have to include that the valve is favorable for ballooning. This is one. You have to exclude moderate and severe MR. Then you have to exclude LA appendix thrombus. Okay. The first two demands transthoracic echo. The last demands TE. Okay. So if I ask you, does Wilkins score based on transthoracic data or TE data? Transthoracic data, exactly. Yes. MR evaluation is also transthoracic data, but you have a chance by TE to evaluate it further. But LA appendix is basically TE data. Exactly. Okay. There is one other important feature which is not included in the Wilkins score, but we are always looking for, and that is what?
Commissural.
Thank you so much.
Pleasure, yes.
Commissural fusion and the symmetry of commissural fusion. Symmetry. This is so important and has a lot of bearing on the success of the procedure and complication. Because you know what we are doing here is just this one. If you look here, the MR is like this. Oh, sorry, the MS. So this one is commissural fusion. You will see calcium here, and you are gonna see calcium here. So you have to make sure that you have symmetrical commissural fusion. Because if you don't have symmetrical, if you have a valve that looks like this,
Will rupture.
so if you have fusion on one commissure and no much of fusion on the other, when you incarcerate your balloon and you inflate it, it will go through the lines of least resistance. So it will go preferentially here with higher force. The force is supposed to be distributed equally among the two commissures. But now this one will remain unsplit and this one will be over-splitted, leading to MR. Okay? So commissural fusion and the symmetry of commissural fusion is part and parcel of evaluation for balloon valvoplasty. And again, it is transthoracic data. Okay? Good.
Okay.
Okay, so can anybody read this one?
Okay, can take it. 65 years old lady has been complaining of shortness of breath, class 3, for over a month. The JB has referred her to cardiology service after cursory evaluation, assuming cardiac condition. In the clinic, the cardiologist picked up soft systolic murmur on the aortic area, coupled with soft second heart sound and fourth heart sound. Echo showed ejection fraction of 65% with moderate concentric LVH and grade 2 diastolic dysfunction. There is degenerative aortic valve, the mean gradient across which was 30 millimeter mercury after exhaustive interrogation. What is the most appropriate next step?
Usually we're going for the invasive hemodynamic because there is the difference between the symptoms and the finding in the echo.
Again, we are going to go for
invasive hemodynamics. Because this patient already symptomatic, we cannot exercise her.
Okay. I agree with you. With a pinch of salt, we are gonna see because cath is not right. It's not wrong, by the way, to go for cath. But let's see the option. You might change your mind.
Option A, send the patient for ABR based on this data, which confirm severe symptomatic aortic stenosis. Option B, invasive hemodynamics will most likely settle the discrepancy between the disclosing higher gradient. C, order cardiac CT to quantify aortic valve calcium score. D, calculate the stroke volume index by transthoracic echo. And E, do transesophageal echo for better visibility of the aortic valve for anatomical area measurement.
I'll tell you honestly, all these options, there is no wrong option here. There is no one that is wrong. We're gonna choose the best. And the best is different than, you know, are we dealing with wrong or right, black and white, stuff like that. No, there is no black and white here. You can send this patient to invasive cath. You can sometimes, and now the guidelines are encouraging to go for surgery in these patients. Yeah, you can do CT for calcium score evaluation. You can calculate the index. You can do TE. Yeah, but what is the most appropriate step? Next step.
CT. I put CT.
CT.
In the last guideline, CT is better.
CT. Type. I don't.
The stroke volume.
To calculate the stroke volume because
Exactly. Yeah. Why? Because you know what? I am still, and the patient is still in the echo lab. Did I finish with all the echo data? No, I didn't. So let's first do my
No.
part before I recommend a multimodality imaging. So in the echo, we are missing one crucial data, which is the stroke volume index.
Yes.
Okay, before I go and recommend some other additional features or additional testing. So I have to calculate the stroke volume index.
Yes.
Now let's calculate the stroke volume index. طبعا هنا للأسف الداتا غير موجودة، ولكن stroke volume index is basically calculated from 0.785 times the TVI of the LVOT times the diameter square of the LVOT divided by
The surface area.
body surface area. So what defines low stroke volume that defines paradoxical AS is what? Less than
index 35 or
5,
34.
less than 35. So if I have a stroke volume less than 35 per meter square, that means I might be dealing with paradoxical aortic stenosis. Okay, then if it's paradoxical aortic stenosis, are you gonna recommend cath? Cath is gonna go into the same problem because cath gradients are also flow dependent, which is low because of low stroke volume. Okay, so cath will be out if I'm dealing with paradoxical AS, unless I'm not so sure of my echo data itself and I am not so happy about the alignment of the jet, and probably I feel I missed the highest velocity because of image quality or so and so, I might recommend cath. But if after exhaustive interrogation and good signals, I fail to demonstrate a gradient above 40 mean, and I have demonstrated the stroke volume lower than 35 ml per meter square, I'm dealing with paradoxical AS, and cath is not in the armamentarium of further workup. But cardiac CT is. Cardiac CT is. So I can recommend cardiac CT, right? What will I be looking for in cardiac CT?
For the calcium score.
Exactly. For calcium score of what? The valve. So we're gonna do aortic valve calcium scoring. The same way we do the chronic calcium scoring. We just put our point of reference or point of interest in the aorta instead of the coronaries, and we calculate. If it is more than 1,200 in female and more than 2,000 in males, the aortic stenosis is most likely severe.
Severe.
Okay. Good. So this is important. Paradoxical AS is so important topic in exam and actually in real life as well. Yani, and recently I was confronted by a heated discussion with interventionists who were willing to take a patient for TAVI. And we did not settle the dispute yet about his severity because the gradient was falling short of 25. I mean, falling short of 40, it was only 25, the mean gradient. Morphologically, yes, the valve look is sticky and degenerative. So they asked me to do the vitamin. The ejection fraction was 60%. The stroke volume index was 33 ml per meter square. So they pushed me to do the vitamin. Do you agree or disagree?
No.
Disagree.
Disagree. Exactly. You should disagree because the vitamin is not for paradoxical AS. It's for low gradient, low EF. Low flow, low gradient, low
ejection
EF.
fraction.
Exactly. So you have to have low ejection fraction. But paradoxical AS is low flow, low gradient, normal EF. That's why it's called paradoxical. It's called paradoxical because though the ejection fraction is normal, we have low flow. Okay. Other thing which is so important, look back at the scenario of this patient. Symptomatic patient, pick up the clinical sign of severity here. What are the clinical signs of severe AS in this scenario?
Shortness of breath, NYHA class 3.
Okay, and clinical signs?
ما لاقي حاجة.
We
soft
have
second heart sound.
soft murmur, soft second heart sound, fourth
Yes.
heart sound. These are all features of severe aortic stenosis. So I
Yes.
think the clinical data is so important to merge along with the imaging data. We shouldn't dismiss clinical data. It's important. And that's why this patient, if you take this patient for surgery without further workup, if you are so sure that the symptoms of dyspnea class 3 cannot be explained by any other reason, is not a bad option. Even if you don't do anything further. If clinically, by clinical sign, there is severe aortic stenosis, the patient is symptomatic because of aortic stenosis, and you have this echo data which is falling short of severe gradient, but we have low flow, I think you can go for surgery. Okay? And now in the new guidelines, I wish you go and review it. I think it's becoming class 1. I'm not so sure, but I think it's class 1 for paradoxical AS. If you are sure that there is no alternative diagnosis or explanation for the patient's symptoms. Okay? Good.
Okay.
Which of the following describes troponins? Belong to the catalyst family, reside in the sarcoplasmic reticulum. All their type can be used in the diagnosis and or prognosis of acute coronary syndrome. TNI is more specific than TNT. The TNT in stroke is due to cerebral tissue increased release. I think we have done this one before. So
catalyst, the catalyst family.
They are not enzymes. Catalyst means enzymes. They are not enzymes. They are structural proteins. So they don't belong to the enzyme family. They belong to the structural protein family. So A is wrong.
Reside in the sarcoplasmic reticulum.
Okay.
Out.
E.
No.
E.
English, no. I think troponin I is more cardiac specific than T. Cancel answer.
Yes, that was the right answer. TNI is more cardio-specific than TNT. Taman, you have done it right, that A is wrong, B is wrong. Now let's go for C. All their type can be used in the diagnosis and prognosis of acute coronary syndrome. How many types of troponin do we have?
3 types.
Which are?
Troponin T and I and troponin
TIC, T-I and C.
Yes. Yes.
Okay? T-I and C. So we are using T, we are using I1, not using CY.
It is not specific for...
Because there is...
Exactly. It's not cardio-specific. So it had the same isomer in the skeletal muscle. Okay? So it's not cardio-specific. So C is out. We are using T and I, so that C is wrong. Now E. High TNI in stroke is due to release from the brain?
No, due to myocardial injury.
It is myocardial injury.
Yes.
أي troponin elevation يا إخواننا is cardiac release. Any troponin elevation is cardiac release. Therefore, you should not say there is no cardiac problem. There is cardiac injury. There is myocardial injury. And this myocardial injury, then it can be ischemic or non-ischemic. In stroke, it might be non-ischemic. In renal failure, might be non-ischemic. In sepsis, might be non-ischemic. But we have some sort of myocardial insult. Okay?
Yes.
When you dispute the elevated troponin with the ER physician or the internist, you should not say this is not cardiac or non-cardiac. It's cardiac, but it's non-ischemic. Okay, it is secondary to the primary condition which is going on. The heart is injured by the stroke, or the heart is injured by the renal failure, or the heart is injured by the sepsis. So you are not going to do anything. The heart is an innocent inflicted bystander. Therefore, deal with the primary condition. But if you see this is ischemic troponin elevation, then you have to do something about the ischemia. Okay? Good. So TNI is more cardio-specific than TNT. In Sudan, which one you are using? I or T?
Both are used.
Both?
Both, yes.
Okay.
ما متذكرة أنا.
في الشاحن أنا
Again, we have we also have done this MCQs before, which is true about atheromatous plaque. Heavy calcification increases the risk of rupture. The thinner the fibrous cap, the more vulnerable.
For the erosion and rupture.
Okay. The thicker the fibrous cap, the more vulnerable is the plaque. The larger the plaque, the more likely to rupture. Proteinases aid to stabilize the plaque. Normal coronary angiogram excludes any degree of atheroma.
No.
Oh, which one?
Proteinase aid to stabilize the plaque. مش؟
لا number 3 the larger the plaque the more likely to rupture صح؟
What about one?
جاوبتي انت المرة اللي فاتت يا ما السؤال ده.
برضه؟
ايوه بتذكر لانه كان الهيفي كالسيفيكيشن قلنا هي دي معناتها more stable. There is no thicker the fibrous cap, the more vulnerable, no thinner. The larger,
more vulnerable.
Yes. The larger plaque is more likely to be ruptured. It could be not, yes. Proteinase aid stabilize the plaque. تخليه هي
No.
That damages and fracture and fissure the plaque.
Yes.
Because it digests the matrix and destabilize the plaque.
Yes. Regarding the normal coronary angio, قلنا هي by panel, it's not a 3D, so we cannot exclude it.
So normal coronary angio can miss eccentric, and normal coronary angio can miss what else? Atheroma in the wall.
Yes.
Atheroma in the wall, because the coronary angiogram is luminogram. It sees the lumen, does not see the wall. It has no camera directed to the wall. But cardiac CT does or has. ليه؟ لأنه الwall is seen quite clearly in cardiac CT. ولذلك cardiac CT has sensitivity approaching 100, negative predictive value approaching 100. لأنها it sees the lumen and the wall, while coronary angiogram just sees the lumen. إذا في atheroma in the wall won't be seen by coronary angiogram.
Yes.
وطبعا you remember that the natural course and progression of the atheroma أنها it start in the wall وبتعمل مرات positive remodeling. يعني it grows outside وممكن يحصل luminal dilatation شوية كمان. تمام؟ Later on بيحصل negative remodeling, which is encroachment and luminal narrowing. So we have positive remodeling, the initial stage, and negative remodeling by luminal narrowing. An initial stage of positive remodeling is missed by coronary angio, لكن not by cardiac CT.
Yes.
Now, a word about heavy calcification or calcification in general. Calcification is considered the healing process. يعني الأثيروما لما يكون فيها large sheets of calcium معناتها it's healing. وبالتالي الهيفي calcium is considered to be kind of protective factor. ولكن spotty calcification is a feature of vulnerable plaque. What is the definition of spotty calcification? Is a calcification less than 3 millimeters. طبعا how it can be measured? It's usually measured in cardiac CT. فإذا الcardiac CT لقت فيه spotty calcification less than 3, it is actually a high risk of vulnerable plaque. Lakin large sheets of calcium is good sign. So you cannot say calcification categorically. It depends on heavy calcification or spotty calcification. Okay, good. Type, we have this 45 patient undergoes percutaneous balloon valvoplasty for pulmonic stenosis, which we don't see so frequently in adult cath labs. The procedure is uncomplicated and the pulmonary valve gradient falls from 80 to 10. He received 3,000 units of heparin during the procedure. 1 hour after the procedure, patient blood pressure falls to 70. His heart rate rose up to 105. On exam, you hear a very loud systolic ejection murmur along the left sternal border. His groin side looks normal, and he's having no discomfort other than feeling light-headed. Which of the following is the most likely cause of his hypotension? Vasovagal reaction, retroperitoneal bleed, acute pulmonary regurgitation, acute subpulmonic outflow obstruction, acute ventricular septal defect.
BR, pulmonary regurgitation.
Acute AR.
AR. If you say AR, I will take you back here. Loud systolic ejection murmur. Why AR? AR should be the systolic murmur. D, which is acute subpulmonic outflow obstruction. Can you explain further? It's a great guess, and it's the right answer.
Acute.
Who chose this?
نشوف السيناريو.
Acute subpulmonary outflow.
Okay, so the procedure is successful. The gradient falls from 80 to 10, and he received heparin. But after the procedure, his blood pressure falls to 70 with tachycardia. And we have ejection systolic murmur. That's all.
Dr. Hatim.
Yes.
Yeah, this is due to infundibulary spasm after
Okay.
infundibulary spasm post البالون valvoplasty.
Okay.
Yeah, which increased the يعني ال RV will eject the blood through a narrowed area.
Okay.
So it will make a and
yes.
to manage it to manage it, we give the patient a beta blocker and fluid just to overcome
Okay, great. Does it has a name or does it have a name? This phenomena?
Excuse me, the voice not obvious.
Ah, really? My sound is not clear?
For me.
So, are you okay with my sound?
Yeah.
Yes.
Okay. So I was asking you, do you have or do you know any name for this phenomena? Yeah, it is called suicidal RV. Suicidal RV. So this is a known complication of fixing pulmonary stenosis. طبعا يا اخواني انتوا عارفين anatomically just a moment there is a sound that's coming from somewhere. Okay, so the RVOT and pulmonary valve relationship anatomically is different from the LVOT and aortic valve. So there is a very big infundibulum, okay? And the relationship is much more complex than on the left side. So what happens is when you have an obstruction in the pulmonary valve, the LVOT, the RVOT is hypertrophied, but it's maintained open because of the high pressure upstairs. When that high pressure upstairs go away, there will be collapse in the RVOT. Okay? So it will lead to a sudden acute RVOT obstruction. And that leads to hypotension. Okay? That's why in pulmonary valve stenosis, when they are fixing it, they give fluid just to combat the possibility of suicidal RV. طبعا في الليفت سايد ما بيحصل، يعني we do TAVI and we fix the aortic valve ما بيحصل because of the anatomical relationship between the LVOT and aortic valve is different than the RVOT and pulmonary valve. Okay? Good. So remember suicidal RV. طيب,
Sorry,
now
Dr. Hatim. So there is no spasm.
It's due to collapse and contraction and spasm of the RVOT. The RVOT is crushed closed, you know, because it was hypertrophied, but it was maintained open because of the high pressure up. Now we remove that pressure suddenly, so it gets contracted and collapsed like that, leading to obstruction. So it is sort of muscular obstruction. It is muscular obstruction, okay?
Okay, thank you.
Type. We have this symptomatic 43-year-old man, known hookah, is referred to you after failing all medical therapy for his disease. Is referred for alcohol septal ablation. Which of the following increases the most regarding the risk of permanent pacemaker after the procedure? I mean, which of the following increases the risk of complication or increases the risk of permanent pacemaker, of the need for cardiac pacemaker after the procedure? History of
scenario again.
Right. The scenario is we have symptomatic 43-year-old man, non-hookah, failed medical therapy, referred for alcohol septal ablation. Okay, and we need to know what is the risk of pacemaker in this patient. It depends on which option here. Ventricular history of ventricular arrhythmia, advanced age, degree of LVH, pre-existing left bundle branch block, or first degree AV block.
Pre-existing LBB.
Pre-existing LV block.
Okay. Why? Why pre-existing left bundle endangers the conduction system and leads to the possibility of pacemaker?
Because they happen
Because during ablation, may cause right bundle.
RV.
Okay.
Traumatic right branch block.
Very good.
Could happen.
Yeah, exactly. So the alcohol ablation damages the right bundle. والانسيدنس بتاعت الدمج دي مرات تصل 40%. Okay. لكن الآن in good hands and better operator and كده it's so much lower. But it damages the right bundle. So if you have pre-existing left and now you have right, there you have complete pop block. Now, septal myomectomy, surgical septal myomectomy damages the left bundle. So if you have pre-existing right bundle, you might have complete pop block. So it's the opposite. Okay? Remember this one. Septal ablation damages the right bundle. Surgical ablation damages the left bundle.
The left bundle.
Okay?
Yes.
Good. Now for septal ablation, what workup do you usually have? And what is the indication of septal ablation in general, whether alcohol or surgical, in this patient?
If the patient symptomatic in spite of the medical therapy or severe LVOT obstruction.
So
And,
why not to put an ICD? ICD is not indicated for symptoms, right? Right?
Yes.
So we have two therapies. We have two therapies for hookup. Therapy for arrhythmia and therapy for symptoms.
Symptoms.
Therapy for arrhythmia or potential arrhythmia and sudden cardiac death, and that relates to the risk factors we know. And you know the conventional risk factor, and the new guidelines have added another 3.
Yes.
Which are?
LV
أو
aneurysm.
خلينا نقول ال conventional risk factors of sudden cardiac death, which necessitates ICD insertion. What are they?
History of sudden cardiac arrest.
History of cardiac arrest.
Surviving arrest, yes.
Family history of sudden cardiac death.
Family history of sudden cardiac death.
Unacceptance
History of
syncope.
syncope. Okay.
Yes. Reduced ejection fraction.
Reduced ejection fraction is not in the conventional. Yes, you are right.
Okay.
The conventional. خلينا بس نخلص من الconventional.
طيب كان عندنا reduce تقريبا في تاب.
اوكي. اوكي. تمام.
كان زمان البلود بريشر ريسبونس لكن هسه بقت اوت تقريبا.
اوكي. And thickness more than.
ايوه thickness more than 30.
Okay. So these are the conventional risk factors. Now the 3 added risk factors are ejection fraction lower than
50%.
50 and
LV aneurysm.
LV apical aneurysm and
yes, and enhance
very good.
let the delivery enhance more than 15% تقريبا.
Very good. So that is MRI based assessment of the fibrosis. If the fibrosis is more than 15% of the myocardium, involved more than 15% of the myocardium, that's a high risk feature. An apical aneurysm is pulsion aneurysm. You know pulsion aneurysm? There's Zenker diverticulum in the esophagus. It's pulsion. It's due to pressure, high pressure in the mid cavity, leading to bulging out of the distal apex. So if you see that one, this is also a high risk feature. And if the ejection fraction drops lower than 50, that's a risk factor. So they have added 3 along with the conventional risk factor, and there is a scoring system to assess where your patient is seated, and you decide about the ICD. So ICD for sudden cardiac death. For symptoms, we have 2, medication or septal ablation.
Septal reduction surgery.
Exactly. If we fail medication, we think of septal ablation. And when we think of septal ablation, we have 2 tracks, surgical or cath-based.
Yeah.
Now, 43-year-old male, I expect surgery because alcohol ablation is for high-risk patient, for high surgical risk patient. If the patient is not high surgical risk, better go for surgical myomectomy. But if he is high surgical risk, you go for alcohol septal ablation. Okay? As per the guidelines. And one important thing in the percutaneous procedure, alcohol septal ablation, you have to use, and it's better to use, a contrast echo. Okay, so it has to be guided by transthoracic echo, because you know what they are doing? They are going for the septal branch, and they are injecting alcohol. This alcohol is 95% alcohol. They call it dehydrated alcohol. يعني بصراحة كده لما تمسك الفايل بتاع الكحول وتدفقه في الأرض ما بيصل الأرض. It evaporates. Very concentrated alcohol. So it's meant to induce necrosis in the muscle. So you are inducing iatrogenic myocardial infarction. Okay? So you have to be precise in selecting the right septal branch. Not only that, you have to make sure that this septal branch is not having a wider area of supply, because you want to limit the damage to a precise area. That's why we use contrast echo to guide them, to select the right septal branch and to make sure that this right septal branch is not supplying a wide area. Because if it's supplying a wide area, this is a contraindication. Because the induced myocardial infarction will be too massive and you lose more than you gain. So contrast echo is an important tool in the in alcohol septal ablation. Now, your patient with HUCM, with AF, is undergoing evaluation. CAD-VASC score is most likely to indicate that anticoagulation is necessary. Come.
No CAD-VASC in HUCM.
Okay.
No need to
CAD-VASC
calculate the CAD-VASC because it is structural.
Okay, type. Now, there is another condition which you also go without CAD-VASC scoring.
Severe mitral stenosis.
Severe mitral stenosis, of course, طبعا, that's a big deal. Yes. لكن هي
يعني كان تقريبا السيروتوكسيكوزيس كانت.
اوكي. هي برضو a sort of cardiomyopathy. It's a cardiomyopathy. Amyloid كمان. Amyloid is also independent of CAD-VASC score. So amyloid AF always anticoagulation. HUCM AF always anticoagulation. Okay?
More than 75.
Exactly.
And non-compact.
Exactly. Type. With regard to the pathogenesis of aortic aneurysm, which one of the following is the most important factor in the pathogenesis of aortic aneurysm? Smoking, hypertension, cystic median necrosis, type 2 diabetes, or FBN1 gene?
Smoking.
هم طبعا كلهم هم طبعا.
Hypertension.
Hypertension. Good. Yeah. It is hypertension. The most important in
cystic median necrosis here, the pathogenesis of the
that's the
aortic
pathogenesis. Yes, exactly. So in which of the following condition does cystic median necrosis occur?
QC.
Which
cystic median necrosis.
You are still here. Okay, I'm so sorry, I went fast. يعني نحن هنا we said
هم كلهم risk factor لكن الباثوجينيسيس بتاعته mainly due to median necrosis.
By the way, Anna, I probably agree with you. يعني hypertension is the model answer provided for this MCQs, but cystic median necrosis is the final common pathway. لكن المشكلة مع cystic median necrosis, it's not the most common cause of aortic aneurysm. Okay? The most common cause of aortic aneurysm is hypertension. Cystic median necrosis, يعني الآن hypertension causes aortic aneurysm through mechanism غير cystic median necrosis. A cystic median necrosis is a particular group of condition that leads to aortic aneurysm. اللي هم دينا مثلا Marfan, Ehlers-Danlos, bicuspid, familial, and stuff like that. So are these conditions the most common causes of aortic aneurysm? No. So hypertension remains the most common cause of aortic aneurysm. Exactly. And this is cystic median necrosis, in which the wall of the artery is infiltrated by mucinous ground substances and cystic degeneration and all of that. So that will weaken the intima and the media. So it can expand, it can rupture, it can dissect. So cystic median necrosis, remember, aneurysm, rupture, and dissection. Okay? Now, antibiotic prophylaxis is recommended before dental procedure in which of the following condition? Rheumatic heart disease with severe MS, prolapse with severe MR, ASD, VSD, previous infective endocarditis. Exactly. So previous infective endocarditis. And even in this condition or in this scenario, it's class what? It's class 1 indication? No, it's class 2B. There is no class 1 indication for prophylaxis. لأنه we don't have clinical trials, we don't have meta-analysis, we just have expert consensus, you know? So it's class 2B. Which of the following condition is associated with lower level of PMP, pro-PMP? Acute coronary syndrome, renal failure, obesity, chronic heart failure, increased age. Lower level.
Obesity.
Obesity, exactly. So higher BMI tends to lower the PMP, pro-PMP level. That's why in the interpretation, you have to adjust the level to the body surface area. Okay? This is important. But the rest of the condition leads to elevation in the pro-PMP. Which one is true regarding the pulse? We are finishing actually regarding the pulse. Pulsus alternans is called death rattle. Electrical alternance leads to beat-to-beat variation of the pulse. Pulsus deficit occurs in VTAC. Pulsus paradoxus is due to increased blood flow to the LA, left atrium, in inspiration. Collapsing pulse is invariably present in severe AR. Sometimes
Pulsus alternans is called.
B is right? Or you said A?
A.
Yeah. A. Okay, great. So pulsus alternans is called death rattle. Maybe I don't know about this, but I know that B, C, D, and E are wrong. Why? Because B, electrical alternance, leads to beat-to-beat variation. We said that that's not the electrical alternance. That's the pulsus alternans. Pulsus deficit in atrial fibrillation. Pulsus paradoxus is due to decreased blood flow during inspiration to the left atrium, and collapsing pulse may and may not present in severe AR. So pulsus alternans, which is beat-to-beat variation of the pulse in severe LV dysfunction, is called the death rattle. Historically, an old clinician who described it, they call it death rattle لأنه associated with severe LV dysfunction, and patient will die soon after identifying this sign. عشان كده سموها the death rattle. Last patient, a patient on Amlor 5 for hypertension, which remains above. Sorry, if somebody can take this one.
Okay, a patient on amlodipine 5 for hypertension, which remain above the charges for his age and clinical characteristics. The best policy is A, to advise about total
the therapeutic lifestyle changes.
Change. B, to uptitrate amlodipine to 10 milligrams. C, switch to an ACE. D, add an ACE inhibitor. E, add an ACE inhibitor and a beta blocker. Yeah, better combination therapy.
Add an ACE inhibitor.
So an ACE inhibitor, D.
طبعا here with hypertension we have different policies. The policy of up titration of monotherapy, the policy of switching from monotherapy to another monotherapy, which is the nastiest one. يعني البيشنت يكون على أملور no control, you switch him to enalapril وتوقف الأملور. This is the worst one. And في
combination therapy
add-on أيوة yes increasing or combination. I think this is the best policy in the management of hypertension, and it's advocated recently. وحتى I think in the European Society of Cardiology a few weeks back, they have even discussed the so-called mini pill, which contains three. You remember? I think 3 or 5.
Pill, yes, one pill with 3.
Yeah, one pill with 3 or 4 antihypertensive at small doses. Okay, they thought this is probably better for the management of hypertension than the strategies we are using now. Okay, so I think the combination therapy right from the start or earlier on, it's better than, and in the combination therapy also, which are you going to choose 2 or 1, adding on the first one you are using, or 2? I think it's better to go by 1 and you increase. يعني the option of adding ACE and beta blocker at the same time is probably too much. I might just choose to add an ACE and wait for some time.
Yes.
Right? Yeah. So I think that is it. And we probably have to stop here because I have held you for quite some time. And thank you so much. Thank you.
شكرا لك.